Orthoentgenography, straight or right angle radiograph. So straight or right angle radiograph, orthorentgenography. It's accurate and comparative long bone measurements. So CT scanogram is more accurate. CT scanogram. So that's where most of this has gone to. So if they are going to do any kind of a long bone measurement, they're not doing. It's very, very rare that you're going to do straight or right angle radiography or the orthorentgenography, also known as the orthorentgenography. It's mostly going to be CT scanogram, but you need to know. So conventional image demonstrates elongation, okay? So the central ray, and then it's going to image that entire long bone, and you're going to have a tape, a stick, a measure stick within that image so they can compare the length. So orthorentgenography, clinical indications, back pain resulting from leg length difference. So they already know that there's leg length difference and you're having back pain resulting from it. Developmental anomalies. So somebody that's already got something going on. Epiphysiodesis, surgical procedure used to shorten a limb. So if a limb is growing too long or too fast, they're going to do this to shorten that limb. And then also you can do bone lengthening surgeries as well. So instead of shortening the limb, you may lengthen one of the limbs or both of them. So the procedure, 3 exposures per image receptor. So 3 exposures per that image receptor, which again is not something that you're going to do because digital radiography is 1 image per exposure. You can't protect the cassette and then have 3 like what is shown over here. So it's going to be 3 separate images instead of 3 images on 1 film. So here, this central ray is centered to the joint. The ruler that they use is called a Bell-Thompson ruler. Okay, very important. Bell-Thompson ruler with radio opaque markings beside the limb. So that Bell-Thompson ruler is going to be laid out next to the limb. It's going to be included in that image, so they can take and see the length of that entire limb imaged by those joints. So from this joint here, they would say, you know, this is the measurement to this joint, and then down to this joint or this lateral malleoli, what is the measurement here and how long should it be according to normal standards, okay? So lower limb measurement, AP hip, AP knee, AP ankle, which is what we saw prior. So AP hip, AP knee, AP ankle. Once again, make sure you roll that leg in 5 degrees to get a true AP. For the hip, you may need to roll it in that 15 to 20 degrees to see that greater trochanter hide that lesser trochanter. So the ruler is placed beside the limb, no movement of the ruler or the limb. So once it's placed, be careful that you're not moving it. It will mess up the measurements and give an inaccurate diagnosis. So don't move the ruler, don't move the limb. CR to head of femur. So they're doing head of femur, knee joint, and ankle joint with the ruler, the length of that leg included in the image. Lower limb, AP knee. So no CR angle. You're not going to angle for that knee. It's going to be perpendicular. CR to the knee joint, and then move the IR to the center to center the knee. So we know that the knee joint is a 1/2 inch below the apex of the patella. So go to that 1/2 inch below the apex of the patella, 0 degree, and image that knee. You're not trying to see the joint space. You're just trying to get 0 degree on the knee. and then the lower limb measurement, the ankle, CR is to the ankle joint. So midpoint of the medial and lateral malleoli. Make sure that it's in a true AP position, which it is. You can see the mortise joint, and then it's closed by the tibia right here. So that's a really well positioned AP ankle, and that was all done by when they set up, rolling that foot in that 5 degrees to get a true AP, and then just leave that hip the way it is with that lower leg rolled in 5 degrees. So upper limb, AP shoulder, elbow, and then wrist. So once again, shoulder, elbow, wrist, just like we did for the lower leg with the hip, knee, and ankle joints. Okay, so the entire the ruler's laid out along the limb. You're not going to move the ruler or manipulate the limb at all, so make sure that it's set up correctly to begin with. Central ray is to the shoulder joint, arm extended, hand supinated. Okay, so the hand is in an AP position, so this shoulder is going to be viewed in a neutral position. You're not going to see your greater or lesser cervical on your shoulder. So your elbow joints, central ray is to the mid elbow. Move the IR to center to the mid elbow joint or the elbow joint itself. And then once again to the wrist, you are central ray to the mid wrist. Move the IR to center the wrist to the lower third of the IR. And that's what they're talking about. So shoulder is here. You image the shoulder at the top. You image the elbow right here. And then you image the wrist right here on this image cassette, either on the cassette with lead blocking the two that you're not using, or if it was a film. But with digital, what you're going to do is you're going to center this, and it's going to be to the center of the cassette, because you're going to do exposure, move center, exposure, move center, exposure. You're not going to have 3 on one cassette that you're going to run. Hope that makes sense. If not, reach out to me and I'll explain it a little bit better. So orthorentgenography, orthoroentgenogram radiographs, so your lower limb and then your upper limb. And you can see the 3 images on the one film. So we don't do that anymore. It's going to be 3 separate pictures. So CT long bone measurements, hip to ankle. So hip to ankle. This is all either in one scan or it is in one long film, kind of like they do for scoliosis series. That's how they would do the long bone measurements from the hip to the ankle. So you can see the ruler here. It's on the film. So this is the CT scanogram of the femur. So this is a little bit easier to do with the CT because it's a built-in program within the scan. So when they scan, all these numbers come up automatically, and they're able to better visualize and get a better measurement with the CT scanogram instead of the individual pictures in the X-ray department. So conventional tomography, review this tomography in the chapter where we talked about the kidneys, because it explains tomography a little bit better. Make sure that you review the words associated with tomography to understand them. So tomography is to obtain a diagnostic image of a specific layer of tissue. And if you remember the tomography we were talking about, it does a slice and then another slice and then another slice, and that's why the kidney looks a little bit blurred, but it's taken, it's imaging and it's slices within the anatomy. So synchronized movement between the tube and the film. So as the tube moves this way, your film is moving this way to collect the data and make that image of the slice within the body. So the tomogram, the resulting image that's produced. So tomogram is the result of the image that's produced. So these are the terminology to review that I want you to go back and look at. So the fulcrum, the exposure amplitude, the sectional thickness, the blur that they talk about, the orthopantomography, and then the object plane. So these are the words that you need to know, the definitions to them. So go back in your chapter and pick up those words and write those definitions. So linear tomographic setup, warning, keep the tube and bucky tray locks open. So these locks need to be open so as the tube travels this way, your cassette, your bucky is traveling this way. If those locks are locked, it's not going to allow that image to be made, and it may damage the equipment. So adjustable fulcrum level attachment. So the reason that this is important is because by adjusting the fulcrum, that's going to tell that tube how far to travel to make that image. So it may have a long arc, it may have a short arc, depending on that fulcrum, how far you're going to let it move back and forth. So tomographic blurring principle, only the object plane and the fulcrum remains in the same position on the image receptor. So that's why, say this kidney is right here, as this arcs, it stays right here in this spot as this tray, your bucky tray, moves back and forth, or from this side to this side. So your tube is traveling, but it's staying right here in the center no matter which way it's going. It's taking that particular image of that spot, and so that is the object that's in the plane. So it's going to remain the same, and that's what's going to be produced on that image. So object plane, so this is the object plane right here, and then your fulcrum, when it travels from here to here to here to here to here, it's still imaging that same object plane and creating an image here as it moves to here, and then as it moves to here. And that's why that image looks a little blurred, but it's creating that entire image in that object plane on that fulcrum. And then your section, your object plane thickness, 10-degree exposure amplitude and a 40-degree exposure amplitude. So 10 degrees, so you're moving less degrees. So say you're taking 3 images. So one at 9 centimeters, one at 8, one at 7. Okay. At 40, now you can take 9.5, 9, 8.5, 8, 7.5, 7, 6.5. As the tray is moving this way, your bucky is moving this way, you have different, you can hit many different levels of layers of that object that you're imaging, where if you're moving 10 degrees, you've got 1, 2, 3. So the amplitude, now you have more options to image that object. So orthostatic breathing technique, this is just a review of why we do orthostatic breathing technique and when it's done. So a lateral T-spine, you're going to use a breathing technique. RAO sternum, breathing technique. Transthoracic lateral shoulder, breathing technique. So the tube and the image receptor are stationary and the anatomy moves. So the natural motion of the lungs moving up and down blurs the ribs, gives you better visualization of your vertebral bodies. The Sternum, the ribs get blurred. You can see the really nice outline of the sternum, and then also the ribs are blurred, and you can see that really nice shoulder through the thoracic cavity. So orthostatic breathing technique blurs the ribs, blurs the anatomy that you don't want to see, better visualize the anatomy that you do want to see. So digital orthopantomography, many of you know this from the dentist. It's just an entire view of the mandible from the right to the left side all the way through. So digital orthopantomography. And then this is what you end up imaging. So that's why they use it in dentistry, because you'll see all of the teeth, upper and lower, on one image. Okay. So I'm going to end this one here. I'm going to come back. The last video is all of the QuizMes that we've got. And then this is the last chapter. So one more video after this, and then that is all of chapter 19